members of the Connecticut General Assembly and the executive branch. With that, I'd like to mention that we have 3 MCs today. Father Nick I can never pronounce your last name. That's awful. Carlustis.
Carlutzis.
Yes.
There you go.
I'm half Greek, so I know that.
Okay, thank you. Katie Gillick.
My maiden name is Skelly. It's a bit easier.
That is much easier. And then Hunter Pagot. He is our youth state ambassador. And so with that, I'll let Father Nick take over, and you can introduce the Lieutenant Governor.
Thank you, Leslie. It's a great honor to have been asked to co-MC together with Katie and Hunter this year's Rare Disease Day, and I have that additional great honor of introducing Lieutenant Governor Susan Beisowitz. Thank you, Lieutenant Governor, for joining us.
Well, good morning, everybody. It is so nice to be with all of you on this snow day that we're having. And what strikes me as I look at the panoramic view of the people who are joining are some of my colleagues in the legislature. Senator Haskell, I hope you're feeling better. I understand you had COVID, so it's courageous of you to be here on camera and join us. And I also see advocates and volunteers, and never doubt the power of the advocacy of passionate volunteers, because people like Leslie Bennett and Myrna Watanabe and Father Carlutzis have all lobbied me extensively, along with many of the other folks who are on the call and those who aren't. And I have a lot of hope, number one, because I know my colleagues in the legislature, folks like Eleni and Will Haskell are people of great compassion who will be working hard for you. And also I have hope because as I was looking at some of the companies that are sponsors of today's event, I see that companies like Alexion and Sanofi are companies that work right here in Connecticut and are working hard every day to come up with cures and therapies to help people who are suffering. And I want to say thank you very much. If any of you need anything, please reach out. And I'll look forward to watching some of the initiatives that you have in the legislature go through the process. And also want to say that I'll see everybody on April 30th at the Denise DeCenzo Walk. She was a friend and a huge advocate for so many people. And with that, I'll give it back to our MC. Thank you so much for having me. It's such an honor for the governor and I to represent you every day in Hartford.
Thank you, Lieutenant Governor, and please convey our gratitude also to Governor Lamont. Again, it's a great honor for us as a rare disease community to have the support of so many compassionate leaders in our communities and state officials and elected officials, and have the honor of introducing another state rep, Senator Haskell, who I believe is with us.
Yes, good morning. Thank you so much for having me, and thank you, Lieutenant Governor, for those kind words. I am unfortunately currently COVID positive, so I apologize for my little bit rough appearance this morning. But if there's one benefit to the virtual world, although I miss joining this group at the Capitol, it's wonderful that we can gather virtually and talk about a cause that's so important. Leslie, thank you for your advocacy. I see my friend Dan Donovan is on the phone. He has taught me so much about rare diseases and how they impact families here in Connecticut. First and foremost, the fact that rare diseases are not rare. We know that just in Connecticut alone, this is the rare disease community includes around 300,000 people, And that's just patients. Then you think about family and caregivers and patient organizations and healthcare providers. So I am so excited that the Public Health Committee, on which I have the honor of serving, is moving forward with legislation that would establish a rare disease advisory council. And I know that, as so many of my colleagues would agree, and especially our Lieutenant Governor, who's throughout her career prioritized the safety and well-being of children, this is especially important for the next generation. I have the honor of serving as the youngest member of the General Assembly, and we know that for young patients, rare diseases can be especially challenging and burdensome. I was really amazed to learn from Leslie that about 40% of all pediatric healthcare costs are attributable to rare diseases and their treatment. That's because these conditions are complex, they're difficult to manage and treat. And of course, this is about much more than just cost. It's about making sure that every child in Connecticut has the opportunity to thrive. So I'm really excited to be fighting for this legislation on the Public Health Committee, and I look forward to being your partner. Thank you for teaching us so much about rare diseases. I believe Connecticut is going to be the 21st state to have a rare disease advisory council. And I know that this needed reform can't come a moment too soon. So thank you, everybody.
Thank you, Senator Haskell, and we wish you a speedy return to normalcy and full health. So appreciate you making time despite the COVID to be with us. Wanted to next invite Representative Mitch Belinsky to offer some comments. Representative Belinsky, are you with us?
Thank you, Father. You would think after 2 years I'd know how to work Zoom, but thank you very much for allowing me to speak. I'm going to keep it brief because there's a lot of very, very good people who want a chance to speak as well. And Senator Haskell did a wonderful job summarizing, the broad need and the help of all the advocates that have put us in the position where we actually now have House Bill 5260 and the opportunity to move forward on this council. I was first introduced to this community by Dominic Cotton, and welcomed, tremendously by everybody, especially by Leslie. And instead of making a long speech today, I just want to celebrate and say, wow, you guys, what an incredible group of advocates. And you got us to the finish line, and now it's just our job to get ourselves over it. So I am so happy and so looking forward to realizing this dream, because I know we've been at it for a long time. So God bless every single one of you. And I am available to anybody at a moment's notice with any questions you might have about anything that we're doing. Enjoy your days.
Thank you, Representative Belinsky, and appreciate very much you referencing House Bill 5260. And it's no question that without the support of legislators like yourselves and Senator Haskell and others who I know are part of the Connecticut General Assembly, this is a team effort, and we're grateful to our fearless leader, Leslie. And I know she doesn't always like to be referred to as that, given her modesty and humility, but I'd be remiss if I didn't acknowledge Leslie's leadership in bringing this ball as far down the field as it is to this moment. And I celebrate with her and with everyone for the House Bill 5260. Just the last call for any Connecticut General Assembly members that might be on and wish to speak. I'm not looking actively at all of the participants, but just in case there is someone from the Assembly.
Hi, Eleni, Rep. Cavros DeGraw from Avon. I'll just make it very quick because I know we have a lot of folks to get to. I just wanted to express my gratitude to the entire community, especially Dom, for all that he's done to bring this to the attention of the legislators, and also to my constituents, Dave and Allison Leeds, while I was aware of rare diseases prior to getting to know them, their sons and my son have been together since kindergarten. They're now in 6th grade. I've really been able to see firsthand the daily struggles that they have with Dave's rare disease, and especially the insurance challenges. So one of my hopes for the advisory council, and whatever legislation we hope will come beyond the advisory council, is that we're really taking a look at easing that enormous burden of having to deal with the insurance companies and getting the right medicines and all of those things. Because whether it's for a child or for an adult, I think that that advocacy piece that either the spouse or the patient themselves or the caregiver has to engage in is extraordinary. I know that many of you spend entire days of your lives trying to make sure that you're getting the adequate care that you need. So that's why this council is so important, because we really do need to hear from the people who are living this, who are having these experiences, so that when we are passing legislation, that we are doing it in a thoughtful way that really does help, as opposed to have good intentions and not really come to bear fruit. So I am on the Public Health Committee with Senator Haskell. We actually we're doing double duty today. There's a landmark piece of legislation being heard in public health on children's mental health, which I know is, I'm sure, near and dear to all of your hearts. So we're here, and then we'll also be there. So thank you so much for hosting us today, and we really appreciate all of the work that you do. Thanks so much.
Thank you, Representative Eleni Kavros DeGraw. There's, I think, some Hellenism there, if I'm not mistaken. All right.
Yeah, so
and so much of what you said, I know, resonates, and it's really beautiful to hear that you are aware of some of those full days that caregivers and I myself, as a parent of a rare disease patient, have spent days with insurance companies, and that's probably a lot of what we'll hear today, because of the limits to some of the access to some of the care and medicines. So I know some of our speakers, as we move along, will definitely reflect back a lot of those realities, and it's just beautiful to know that there's a compassionate partner in the state legislature that will help us with a rare disease advisory council. Without further ado, I wanted to introduce a co-MC that we have this year in the person of Katie Gillick. And Katie doubles as a thyroid cancer survivor and a rare disease patient who was diagnosed with post-surgical hypoparathyroidism in 2019. Following her diagnosis, she launched into multiple patient advocacy roles in her local community with the goal of driving awareness and change. And as a member of the community, she currently volunteers with the Connecticut Rare Action Network and is on the board of managers of the Yale New Haven Hospital Auxiliary. As a patient, she has served as a community advisory board participant for rare disease pharmaceutical research and is currently one of 76 patients in the entire world in a phase 3 clinical trial for hypoparathyroidism. It is with much gratitude, pride, and humility that Katie returns this year to speak as an advocate and as a co-MC for Rare Disease Day. Katie, would you like to introduce?
I would love to. Thank you so much, Father Nick, for that wonderful introduction. I'm so very honored to have the opportunity to be with you all again this year and to share in this event with you. As Father Nick had said, my name is Katie, and I do live in Shelton, Connecticut. Last year, when I spoke to you, I told you about my disease. I told you how hard I was trying and how much I was struggling. I told you that I was spending hours at medical libraries, reading medical journals, attending virtual conferences, and putting together my own patient and medication summaries. Last year, I told you about a doctor who told me to limp along. But let me tell you about this year. This year, I was accepted into Columbia's post-baccalaureate career changer pre-med program, which is the oldest and largest program of its kind. I went from studying in the medical library of the institution where my rare disease journey began to being accepted into the post-bac program of the institution where I am now one of 76 people in the entire world in a phase 3 clinical trial for hypoparathyroidism. Now, let me tell you why I declined. I spent the first half of my 20s working tirelessly to regain quality of life for the second half, and I did. I did because I gained access to a doctor who was well educated about my disease and who provides me with the resources I needed to feel better. This is my doctor at Columbia who encouraged me to enter into this clinical trial and who simply wouldn't rest until I felt well again. This doctor is so invested in her patients that she is actually in attendance today listening to me speak. My doctor has helped me to create what my disease had begun to destroy: choice. I have these choices now because my disease is not choosing for me. Because of her involvement in my care, I don't need to be a doctor and I don't need to save myself. I can do this. I can do anything. I used to play softball as a kid, and for 10 years, I exerted the same effort on and off the field as I did preparing to tackle my own disease. One time, when I was in a hitting slump, one of my coaches, having essentially given up, told me, "You can't make a turkey fly." I'll have that coach know that I just recently made a semi-pro women's softball team, and the number on the back of my jersey is 29 in honor of all rare diseases. Not only am I not limping, I'm flying. And the moral of my story today is I think people should stop telling me what I can't do. Thank you so much, Leslie. Thank you, Nord, for continuing to have me involved in this amazing event. And thank you to all of our legislators who carved out the time out of your busy schedules to be with us today. It just means so much to all of us. And it is now my pleasure to introduce Hunter Pagot, our Nord Youth Ambassador and patient with SMART-1, and my co-MC. Hunter, please go ahead and take it away.
Good morning, everyone. Thank you, Katie. Thank you, Leslie. Thank you, Father Nick. And welcome to the Connecticut Rare Disease Day event. I've been a lifelong advocate for those with my extremely rare disease, SMARD1, also known as SMART, or spinal muscular atrophy with respiratory distress, and also for everyone battling rare diseases. To give some perspective, out of about 8 billion people on planet Earth, there are approximately 70 people with my ultra rare respiratory neuromuscular disease. It has been my honor to speak and advocate publicly in numerous venues, including classrooms, hospitals, colleges, police stations, fire stations, state and national conferences, and here at our state capitol this past decade. Due to the fact that pretty much no one on the planet, except for a handful of researchers and physicians, had heard of SMART-1, I began a campaign when I was 7 years old to initiate legislation for a Connecticut state law for a SMART Awareness Day. 7 years ago today, I testified in a public hearing in the LOB alongside Senator Fasano and House Representative Iaccarino, and House Bill 6100 was advanced. With their support, in addition to my family, my friends, and additional local representatives, we accomplished this goal together when I was 9 years old, establishing every February 10th as Connecticut SMART Awareness Day. Ironically, I was unable to celebrate this year on February 10th as I was ill due to significant visual difficulties experienced from poor access to school. Upon being asked to discuss a considerable life challenge with everyone today, and in light of the aforementioned, I can honestly tell you that receiving a free and appropriate education has been a massive uphill battle for myself and for my family, literally since I was a toddler, and long before, to coin a term, I set wheels in a school. Despite having an IEP with detailed accommodations in place, inclusive of customized school healthcare plans created by my medical team, I have faced and sadly continue to face difficulties in ascertaining access to my public education, such as legible materials and appropriate remote access, to name a few. This has deeply negatively impacted me in a myriad of ways it never should have, notably limiting my access to my education. Those with rare diseases should not have to endure great and lengthy hardships and high costs simply to receive their education and to have opportunity to self-actualize. Having a rare disease is more than enough to manage as a person and as a student. This is one of the reasons why being here together today is so very important to me, to shed light on the outstanding challenges faced by those with rare disease, just as I did so in public hearing on this very day in 2015. I am very excited about House Bill 5062 and have great hope a Connecticut Rare Disease Advisory Council will mitigate hardships for our rare disease community in numerous ways. I promise to remain a passionate advocate and continued dedication to raising awareness, increasing education, and hopefully inspiring others to transcend beyond stereotypes, labels, and discrimination. Everyone deserves to live their best lives. Thank you. Back to you, Father Nick.
Thank you, Hunter. That was incredible, and we're grateful for what you do for so many more than you realize on behalf of the patient population, but inspiring, I hope and trust, another generation of emerging young adults like yourself, having navigated through childhood, adolescence, and now continuing as you are. You're an inspiration to us all, and we thank you. I wanted to take a moment just to read Senator Blumenthal's statement for Rare Disease Day 2022, as he could not be here with us today, before moving on in our speaker list. This Rare Disease Day, I'm proud to join the National Organization for Rare Disorders as we renew our commitment to supporting patients, families, and essential caregivers. With robust federal investment, we can and will spur innovation of research, treatments, and cures for those living with rare diseases, saving countless lives in Connecticut and across the country. Again, we thank all of our supporters within the state legislature, all of our sponsors, NORD, and all the folks who today have come out to support us and to hear the stories of our speakers. And we have next up on our agenda a group from Pennsylvania, two women, Jennifer Wesco and Marie Conley. Jennifer is the founder and executive director of Wesco Foundation for Pulmonary Fibrosis and a member of the Pennsylvania Rare Disease Advisory Council. Rare Disease Advisory Council is sometimes abbreviated as RDAC, so you might hear that. And together with Jennifer, Marie Conley, the founder of the Conley Cushing's Disease Fund and chair of the Pennsylvania Rare Disease Advisory Council. Marie and Jennifer will be talking about their experiences in Pennsylvania with their RDAC, Rare Disease Advisory Council. Jennifer, Marie, thank you.
Good morning, everyone. It is such a pleasure to be here with you this morning. Thank you so much for the invitation. On behalf of Pennsylvania Rare Disease Advisory Council, it is a true honor to be here to talk about rare disease and the development and creation of a Rare Disease Advisory Council. As Father Nick had mentioned about where we come from, I am the executive director of Wesco Foundation for Pulmonary Fibrosis, steering committee member, secretary, and have a pleasure working with Marie and the entire council in making a difference for the Rare Disease Advisory Council. Next slide, Kristen. Thank you. Our mission statement, as you can see, is clearly, as we all are on a united front, improving the lives of Pennsylvanians who live with rare disease, in having a resource for patients, families, physicians living with rare disease. And as we all are same mindset, we always look to the future. And so what's our vision statement? We want to look forward nationally of coming together. Senator Haskell had mentioned about 20 rare disease advisory councils. And so many more. We have many more to get to where where the entire United States is advocating moving forward for the rare disease rare disease community. So we look forward to being a national leader in doing so and transforming the lives affected with rare disease through collaboration. We hear that all the time, right? It's such a collaborative effort, support, education, and advocacy. Next slide, Kristen. So, of course, we want to lay out what we're talking about this morning, and we want to make sure we start where the initial catalyst where this all had happened, you know, where we developed and how we developed in transitioning of what we're doing now and how we're going to be looking to the future. Next slide, Kristen. Thank you. Joe Coyne had a conversation with Representative Marcy Topol on an evening, and that's where it all started. Our friend Joe Coyne, a huge advocate for the rare disease community, and it all started with his son having Batten disease and wanting to make a difference. And it is very understood as we hear listening to everybody and seeing everybody this morning, the story is profound, right? And when we move forward, getting that story, the experience, and coming together with our legislation, no matter where we are, is paramount. And so it's such a pleasure seeing legislators here this morning, of course, and making things happen for Connecticut. So again, we're very appreciative being here this morning and seeing all of that. And that's where it begins, right? And so this is where our story began. Next slide, Kristen. So Act 14 in Pennsylvania was passed July 7th, 2017. And there are questions of, well, how are other RDACs created and what are they comprised of? And they are all different, right? And each state has different momentum and processes and what that looks like. With ours, and Marie's going to talk about this later, it's comprised of many parts through this entire rare disease community. And so Marie will be touching upon that. And, you know, in terms of funding, it's how are we going to make this happen? And so with Pennsylvania Department of Health was a big part of our process. And as we look forward, but other funding comes from higher education, research, grants, which of course that will come into play for sure. And, you know, a real short, very profound, and Marie and I and our council talk about this often. And it was our first meeting. We all came together, we sat there, great, you know, it was very, very exciting. And we all introduced ourselves and what we're there for. And then we had our leader at the time put a white hat on. We all put a white hat on. And when we did that, we knew that we are united in one mission, in supporting the rare disease community. We have all of our rare diseases that we are so passionate about, and it is so consistent beyond state boundaries. And so when we put those put our hats on, we saw all of us united, and we see that here this morning. It is such a pleasure to see that consistency and the passion that Connecticut holds. Next slide, Kristen. So we have a rare disease caucus, and it encompasses, as Representative Marcy Topol moved on out of office, we have Representative Barb Gleim, and we have Representative Mark Longetti, Senator Judy Ward, and Senator Maria Collette, and all bipartisan, united together in one mission in moving forward for the rare disease community and making a difference and changing people's lives. For that, I'm going to move on and pass it over to Marie.
Thank you everyone for allowing our council to be a part of your day today. Can we have the next slide, please? As Jen shared, each council is made up differently, not just in terms of the way that the legislation is written, but how each member and council is constructed. This is how Pennsylvania and the representation that is built within our language. So these are the individuals that the legislature have put in. This actually is a very fair representation of the stakeholders that were at the table and part of the discussion in building out the legislation. The way we also have as a council the ability to add ad hoc members. In the essence of time, we will not play it, but this is actually on our website. But there is a video that all 4 caucus communications directors came together and helped us produce a video where all 4 are on there, along with interviewing some of our council members and rare patients, talking about the importance of the council and the collaboration between the legislature and the Rare Disease Caucus. Next slide, please. Jen did touch on this a little bit, but the evolution of our council started where, number one, we walked into that meeting. Each of us came there with our own diseases, our own advocacy, whether we were coming in with our own diseases, our own support groups as parents. And then once we came together, we were one voice advocating on behalf of all rare disease patients. And so we designed, and you saw our mission and our vision statement. We designed what our goals would be. The way that our act was written, we had to report and produce a report in year 1 and year 2 for our legislature, which had to be sent to the committees of health. And we also worked on establishing a relationship with our rare disease caucus co-chairs. In 2009, the structure changed a little bit in that the Secretary of Health gave us much more autonomy. When the act was created, there really wasn't any funding structure attached to the legislation other than they supported the cost of a facilitator. And we were very appreciative of this since we had to do 2 reports, but they did feed us, which when you have to do 2 mandated reports, food was very important to us. So we did appreciate that. But we did have to find some opportunities for funding. And so we were able to create a relationship with a foundation to become our fiscal sponsor, which allowed us to then look for grants, which has become a very important opportunity for us to look outside of just asking the legislature for funding. In 2009, when that structure did change within the Department of Health, we created a governance structure. So we have our steering committee, we created bylaws. Again, we established that funding stream, and we worked with external partners for funding opportunities. Next slide, please. One of our priorities that we identified early on, given the fact that there are so many different needs of the rare community, we did not want to go to the legislature as mandated to advocate on behalf of rare disease patients based on assumptions. We needed data. And there are no organizations, whether it's in the Department of Health, Department of Insurance, that have collected any actual data based on the needs of rare patients. So we worked over 1.5 years on creating a survey that has been vetted. It was led by one of our doctors on our council. We went through, beta tested it, have an IRB approval, and we were ready to launch. And then COVID hit. So we waited a little bit, but we did know that we needed to push this out. So we did push it out in the middle of COVID, but we are in the middle now of doing almost what we're calling a relaunch. And our goal is to take all of this data, and then we will take that, work with our epidemiologist, and then as a council, we will be able to go back with data to then go to the legislature based on what rare disease patients and their caregivers are saying. The questions deal with healthcare, support groups, their journey of diagnosis, quality of life, how long does it take you to travel to your provider, cost, whether they're out of pocket, support groups. So we do feel like we are covering all of the costs because, again, we did some mini focus groups on that. Next slide, please. We're very careful about what we do and what we jump into because what we do try to do is make sure with every rare disease organization, we cannot be all things to all people. And that's not what our council is. We know each council is set up differently, but we cannot be an active voice for every single council. Our job is never to take away funding or any individual councils or any individual rare disease patients' active advocacy on the Hill. Our job is to be the overall voice for the rare community. So in those particular situations, we do help to advocate for legislation. And one of the things that we did realize during COVID is when there were different qualifications early on as to whom could get the vaccine, so many rare patients were left off and they were put back onto the individual states. With our rare disease caucus co-chairs and our council, we advocated and pushed that rare disease patients with suppressed immune systems that weren't on certain drugs could get onto the list. Next slide, please. As we look to the future, our act expires in 2025. So we decided early on to always look very strategically, almost like a pool player, and wanted to set ourselves up so that when the act does expire, we are already in a position to transition into a 501c3, because we do not want to see all of this hard work go and expire when the act does expire. So we have created everything so that our structure can be turnkey and move into a 501c3 organization. We have worked and were able to advocate strongly with the legislature, and we actually did basically an ROI budget request last year so that they could see what we were asking for funding, and we explained exactly what their ROI would be if they were able to give us the funding. So that is helping us with a PR campaign for this year for the survey. We are holding a statewide summit later this year, and we will just continue our advocacy efforts. And we think a lot of what we will do will come from the data of the survey. Next slide, please. So with that, we just wanted to say how grateful we are for this opportunity. And of course, we will continue to be a resource to Connecticut in any way that we can. And we know that we can speak on behalf of our caucus co-chairs that they would be happy to talk to any of your legislators to advocate for House Bill 5260. We know that our council has done tremendous things for the rare community because rare disease affects and their rare diseases affects patients and their caregivers in a different way. We need to be seen through things through a different lens, and that's what a good RDAC does. So thank you very much.
Thank you, everyone.
Thank you, Marie. Thank you, Jennifer. I wanted at this point, being mindful of our state legislators and their schedules, to call on Representative Jillian Gilchrist, if she's able to offer some remarks.
Yes, thank you so much. I just sent a note because I have less than a minute, but just so happy to join you all this morning. Just wanted to say how much I've learned from you all about rare disease and how it impacts folks here in the state of Connecticut. And I think it's a fantastic idea to have an advisory council because we need to understand your unique needs and how not only
what policies could support you as a community, but also how the policies we're passing would impact the rare disease community. So just thank you for your work. Know that you have an ally in me. I serve as vice chair of the Public Health Committee, so I look forward to seeing many of you at our public hearing. And with that, I'm going to jump off because I have another meeting. So have a great day. Thank you.
Thank you. Thank you for staying on, Representative Gilchrist. All right. With that, we'll move further down on our agenda. I appreciate everyone's flexibility as we try to fill our space with as many of our speakers as we can, and being mindful of the time as well. Next, we have Dr. Karen Rubin, Professor Emeritus Pediatrics at the University of Connecticut School of Medicine and Medical, and the Director of the Connecticut Newborn Screening Network. She'll provide a brief overview of the Connecticut Newborn Screening Network and explain its connection to rare disorders. Dr. Rubin?
Yeah, next slide, please. Okay. First, I want to open with a thank you for Leslie for giving me the opportunity to speak on behalf of the Connecticut Newborn Screening Network and explain its really direct connection to rare diseases. As you all know, newborn screening is one of the most amazing and successful public health programs, and it exists in each state. It's often called baby's first test, obtained by a heel stick. It detects babies with serious but treatable rare genetic, metabolic, and hormonal conditions. In Connecticut, we're a leader in that we identify nearly 70 rare disorders before a baby becomes sick and enables providers to begin treatment within the first few weeks of life. This perfect bundle of joy pictured here is Connecticut newborn Abigail Hurley, born on October 1st, 2020 in the Hospital of Central Connecticut. Abigail got her newborn screening blood spot at the right time, completed at 24 hours of age, and her newborn screening sticker, which says newborn screening saves lives on her bassinet. And this is one example of how the Connecticut Newborn Screening Network has worked hard to increase newborn screening awareness. Next slide. Thank you. This is a simple schematic of the network. When a newborn screen is collected, it is sent to the State Public Health Laboratory and Program in Rocky Hill, Connecticut, where the sample is logged, prepared, tested, interpreted, and the results are reported out to the network. The network responds to all infants in Connecticut with out-of-range newborn screens by working behind the scenes to provide a vital link between every infant's primary care provider, specialists, and the families to ensure timely access or connection to care, which is on the top of this slide. And that's the connection to care. Other roles of the network, when we were funded through a DPH grant in 2018, our first step was to really get off paper, to develop a fully electronic system. We did this by building an electronic registry within an electronic health record, and also built an interface to connect bidirectionally to Connecticut's electronic MAVEN system. Other roles of the network is in close collaboration with the newborn screening team at the state lab to support all stakeholders. And we've also engaged in a wide scope of educational activities and awareness activities to providers and families. The network also provides timely access to genetic counseling, and we were able to attain some additional funding through the CARES Act to actually develop ability to schedule telehealth visits with our genetic counselor. And more recently, as is the national trend, we're really engaging in developing a model to not only track, but optimize long-term follow-up of the newborn screening population. Next slide, please. Just to give you an idea of the volume, since March of 2019, when our virtual registry went live, 1,289 infants have been referred to the network for responding to out of range newborn screens. And of this, 319 infants were diagnosed with rare disorders. Next, in the past year, 35,557 babies were born, 481 had out of range newborn screens, and 113 infants were diagnosed and promptly connected to care for early intervention. Next slide, please. The network's innovative, integrated, coordinated model links patients to care quickly, and this is very critical. We now have data to show that 100% of patients are linked to care, which is often the first steps in the diagnostic evaluation, and for those that are needed, immediate connection to specialty care teams within 24 hours. And 90% of patients are linked to care in less than 2 hours. The linkage to primary and specialty care and early intervention dramatically improves short and long-term health outcomes by reducing mortality, morbidity, and equally important, by reducing the emotional and the cost burden to families. A rare disorder advisory council could further inform the network where we need to focus our improvement efforts. I just want to mention that in 2021, the first infant in Connecticut identified with SMA1, a devastating neuromuscular disease, through newborn screening, was cared for at Connecticut Children's by a team led by neurologist and international muscle disease researcher, Dr. Jula Aksadi. This infant underwent gene therapy shortly after birth, and just last week, Dr. Aksadi notified our network team that at this baby's 18-month-old visit, she was developing normally and is healthy. He said this result in his career in this area is unprecedented. A rare disorder advisory council, again, would further inform us how to make further improvements in access and other related aspects. Next slide, please. The network is committed to ensuring what I call whole family needs are met. As we begin to shift our focus onto long-term follow-up outcomes, we're going to be answering the following questions. How are these children doing over time? And more importantly, how can we optimize long-term physical, developmental, and emotional health? Because as we know, and as I know as a pediatric endocrinologist, spending my career taking care of children and adolescents and families with rare and not so rare demanding chronic conditions, we know that there's an impact not only on the physical health, but often developmental and emotional health as well. So what have we learned? And what have we learned really by in families, newborn screening families? That they often did not receive adequate early education, that they need more resources, that they want to connect with other families, that they want assistance with educational advocacy, that they often lack access to genetic counseling when they need it. And they often describe themselves as feeling unsupported or alone. So again, families need a voice at the table. And also we look forward to the Rare Disease Advisory Council providing a feedback loop to the network so that we continually to work with you to make these necessary improvements. And with that, I'd like to say thank you for the opportunity to speak. And Leslie, we hope to continue to work together closely with your team.
Thank you, Dr. Rubin. Great presentation, and it really helped a lot of people. You succinctly, encapsulated all the problems that our patients have with newborn screening, and we do look forward to working with you. Thank you.
Welcome.
Thank you again, Dr. Rubin. I'd like to introduce our next speaker, Dr. Michelle Spencer Manzon, who is an associate professor of genetics and of pediatrics at Yale School of Medicine and associate chief of clinical genetics operations and pediatric genomics discovery program at and a mom to a child with a rare disease.
Thank you so much for letting me talk. I actually have a few slides I made. Am I able to share my screen? Is that possible? I don't know who's the host.
Yes, I'm sorry, I was on mute. Yes, give me 1 second.
No worries, take your time.
And I just.
All right, wonderful. Okay. Can everybody see my screen okay?
Yes.
Yes.
All right, wonderful. So I've already been introduced. Thank you very much for the kind introduction. So, I mean, a lot of people I think I do know on this call. So I'm a physician in genetics. So I take almost exclusively rare diseases. In fact, many of my colleagues call me the zebra doctor. So, but thing I think not everybody knows is that I'm also a patient and a parent as well as a provider. So I kind of just, I only have 5 minutes, so I'll try to keep to that. But I'm not used to sharing my story. I'm used to talking about this from a provider standpoint. So I think I'm happy to do this and for what it's helpful for other people. So I'm going to start quickly, I think, with the fact that I'm a patient with the rare disorders. I think it's probably, some people know I have a child, but I think very few people know that I'm actually a patient as well. And so I have a bleeding disorder. So I have von Willebrand's as well as a platelet release disorder both. And honestly, when I was 14, I had a major jaw operation and hemorrhaged and was in the operating room for 6 hours and nobody clued in that I had a bleeding disorder. And I had bruising and bleeding and menorrhagia and nobody clued in I had a bleeding disorder. And then I was getting ready to have a tonsillectomy at like 25 or something. And the ENT doctor said, this is not a good history. We probably should get this looked into. And no one had mentioned this. I had brought these things up for years. And then I was ultimately diagnosed with that. Unfortunately, since the tonsillectomy is a very blood loss surgery with a lot of blood loss, I did not hemorrhage that surgery. I've been taken care of and my life has changed. I will tell you, and I kind of take it for granted because this is a treatable disorder, right? Until I was out hiking in the at Teddy Roosevelt State Park. And we went into the wilderness because I was bound and determined to see this petrified forest. And we got caught in a hailstorm that wasn't supposed to happen. We were 1.5 miles out from our car. And I actually got hit with hail that was really the size of golf balls. It was really big hail. It was actually one of the scariest times I've ever been in the wilderness. And I've been doing this my whole life. And I ended up developing compartment syndrome in my arm from it because I just kept hemorrhaging and I couldn't stop and I didn't bring anything with me. And I was in North Dakota. And then I realized just how lucky I was when I came home to be in Connecticut where there are hospitals that are closed that could deal with this. I was hours out from a hospital, didn't have hematologists. I ended up calling home and getting help from my doctors here. But I can tell you, Connecticut has wonderful resources, wonderful doctors. And I'm very pleased with the care we get here. And I hope we can continue to bank on that because I feel like if I was living there, God knows if I'd ever been diagnosed and I would have had to have major surgery as opposed to getting medication to help me clot to start, just to starve off getting the worst of that compartment syndrome. And then this is really not what I was going to talk about with my son, it's not the main thing, but I also pass this on to my son as well. So he also has that. And I think that's one thing as a geneticist, and I think we need to think about some of these things we're talking about are not passed from parent to child, but in many cases they are passed from parent to child. And rare diseases is oftentimes a family, a family eccew. So what about being a parent? So as a parent, it's been a whole much bigger deal. Like everybody, I was ecstatic when I was pregnant. I was a 4th-year medical student. I was going off to residency. It was all very exciting. My pregnancy was pretty unremarkable. And then, and my son was born and, everybody said everything was okay. I said, I don't know. It seems like he's having some issues. They sent us home. 24 hours later, we were in the PICU. And so we were in the PICU for a couple of days. We spent some time there. They did some things. They said, oh, no, it's just neonatal, some neonatal infection. He got antibiotics, he got fluids. We went home. And this started this long diagnostic odyssey for us that lasted 16 years. And that's 16 years in the setting of me being a geneticist. And, we had feeding issues and we had issues with making developmental milestones. I mean, mentally, I've been very fortunate. He has not had any issues, but lots of motor issues, issues with recurrent infections, issues with low MIPS and MEPS, couldn't cough and clear. And they would wax and wane. He'd get better, he'd get worse, get better, he'd get worse. At one point, everybody thought he had a mitochondrial disorder, hence how I became a geneticist, which was not my original career goals. And ultimately ended up having a neuromuscular junction disorder. And fortunately for us, that does have some treatment. And he's had a very good response to pyrostigmine, but it took us 16 years to get there. And I will tell you, I have training. He got physical therapy, occupational therapy, speech therapy. I took classes in how to do oral motor therapy that had to be done every day. And that was the only way to get through feeding. We would spend an hour and a half, 2 hours, sometimes at the table, just getting through feeding. Because I was, we're just, trying to avoid a G-tube at that point, still having failure to thrive issues. He was 10 or 11 before he could eat an apple. He was 15 or 16 before we were able to ride a bike. I mean, there was all sorts of things like that. And it was a struggle, right? I was a full-time doctor trying to balance therapy appointments. We had pulmonology appointments, hematology appointments, neurology appointments. Nobody could tell you what was going on. We just went to doctor's appointments, and I'm trying to do this and rushing in and out and do the things around my clinic. And everybody who scheduled an appointment with me knows how hard it is to get in. But lots of people, right? It's hard to get in. And then, it's on the phone with insurance companies because someone didn't put the referral in properly, and you're having to get that redone. And, it's a lot of stuff not covered by insurance. Adaptive equipment to do the therapy at home is not covered by equipment. It's not oftentimes covered by insurance. And just the emotional costs. I mean, there have worked days, even with all my training, even with all the resources and support we have, I would just sit and cry for like half an hour in my study so nobody could see me because it's getting through there. But I will tell you, I think it kind of had my son is my hero. He is the most optimistic kid. He is now required to take medicine 4 to 5 times a day. He's got to take medication every 4 hours. And he's ecstatic to be taking medication every 4 hours. And I think about how many people complain about having to take their heart pill or whatever thing, once or twice a day. He just feels so much better. He had such horrible dysarthria that had the pyrostigmine. That's the first thing when he went back to school as a senior in high school and he was finally on it. The teachers were like, why does he sound so clear? Like, what did you do different? And I'm like, oh my God, he's on medication. And he's not getting sick as much. He can cough and clear better. I mean, he still has decompensations. And we had a really scary one not 2 years back where he could barely walk. And that's actually how we finally ended up getting a diagnosis, at least partial diagnosis, although we still can't molecularly confirm it. But he has taught me to be resilient. He has been positive. Besides that, he is grateful for everything he gets. He has worked so hard. Maybe he's not as good in sports, but so he does other things, and he's very creative. And he's just a joy to be a parent. We have a very close relationship. He has taught me to accept life better. He taught me to live life better. And so, as hard as being with a child with rare disease, as hard as it is to have a neuromuscular condition, watching him has definitely made me a better doctor and a better person. And these are just some pictures. So, one of the great things here is after he was, we all love to do outdoor stuff. On the pyrostigmine, we're actually able to go and tackle Yosemite because Yosemite is a very hard hike. So there's one picture there and just some other pictures from our trips together. And then what has it taught me as a provider? It's a privilege and honor to be able to take care of patients with rare disease. We have amazing families with amazing advocacy who do amazing things every day that I don't know how I would do there. Take great care of their kids. I am so grateful for the people who have shared this with me and hope we can continue to move that. I do think I have in recent years started sharing my experience with some of my patients, and I do think that has helped me be a better doctor and sometimes help them. I think I've had when families they're crying hysterically and feel overwhelmed by a new diagnosis, I'm like, I've been there. It's going to get better. I just promise you it gets better. And also I think I've learned a lot of trips, having done feeding therapy at home or physical therapy at home or all that stuff. I'm like, oh, this and this works and try this. And it's just how long it really takes, regardless of what everybody says. I think that's helped. And I think it's helped me too for partnerships, right? Like I think taking care of rare disease is partnerships between the patients and the families, between other doctors, between lots of different healthcare providers. It takes a village to optimize this. So I really worked on partnerships, collaboration, building bridges. I think is just so key to caring for the rare disease community, because yes, we're rare individually. No, we're not rare as a community. and together we make each other stronger. It's really a lot of synergy. And just briefly here, I wanted to just kind of briefly bring up, I'm thrilled to be part of the Yale team. I'm thrilled to be part of Connecticut, where we have 2 amazing children's hospitals. We have multiple amazing adult hospitals to care for patients. We have a big team of people here to take care of it. We're continuing to expand. Our programs have been recognized nationally. The multidisciplinary clinics here have really been something that has been a baby of mine. We had very few multidisciplinary clinics when I started at Yale. Most of these, with the exception of a couple, are ones that I'm actually in charge of, because going to 16 appointments is hard, right? And your doctors don't collaborate, can't talk as well if they're not in the same room. So we started a neurogenetics clinic. We already had a robust MDA clinic. I joined that. We hadn't previously had genetics. We have a multiple disciplinary cardiac genetics clinics. I even, we have skeletal dysplasia clinics now, hereditary seizures. And even one thing we've done very recently is have a genetics pediatric surgery clinic, because I remember being terrified of having my child have to have surgery. Now we have surgeons we can see them together, answer both questions. And we have surgeons now who are very experienced in taking care of rare diseases and the differences in doing that. So I hope to continue to grow this. I hope to continue to grow the collaborations, not just within our own institution, but throughout the state. Because I think as a community, we need to all work together to take care of these patients. And so thank you to all the amazing sponsors. I'm so excited. There's so many people who are supporting rare disease. And many thank you for letting me share my story.
Thanks, Dr. Manzon. That was wonderful.
How do I stop sharing? I don't remember how to do this. Here we go, wait.
Thank you so much, Dr. Spencer Manzon, for sharing your story and your perspective. It's always so helpful to hear from parents, from patients, but particularly from providers who themselves have gone through this and can offer that sympathy and that support. And next up, we now have Arnita Roberts-Christie. Arnita is a registered nurse for more than 35 years, and she has worked in multiple medical settings and disease states, including academic hospitals, occupational health, insurance, and the pharmaceutical industry. Arnita is currently employed by GlaxoSmithKline, or GSK, as a patient engagement liaison. She has a passion for educating patients, families, and healthcare practitioners about rare disease, as well as raising awareness about the impact of these diseases that they have on communities. She's a longtime Connecticut resident, and we very much look forward to hearing Arnita. Please go ahead.
Thank you. Good morning, everyone. Can you just respond back to let me know you hear me?
We can.
Yes.
Okay, great. Good morning. As was introduced, and thank you, I am Arnita Roberts-Christie, and an employee of GlaxoSmithKline, or GSK, a biopharmaceutical company. One of my roles at GSK as a patient engagement liaison is to educate patients, caregivers, and family members regarding the diseases of lupus, severe asthma, and rare diseases. The education and information I provide today is for educational purposes only and is not meant to take the place of a patient having a very open and transparent conversation with their healthcare provider. So we've heard a lot about rare diseases, and for those of you that may not know, I want to put it more into context. Rare diseases are health conditions that affect a smaller number of people as compared to the other prevalent diseases in the general population. A rare disease is identified as any disease, disorder, illness, or condition affecting fewer than 200,000 people in the United States. Of the 5,000 to 8,000 diseases that are classified as rare, I am grateful for the opportunity to provide information regarding 2 of those rare diseases today: Hyper-Ecenophilic Syndrome, or HES, and eosinophilic granulomatosis with polyangiitis, also known as EGPA. However, I want to make sure I draw attention to the fact that although I just quoted you some numbers, there are human bodies behind each of those numbers. These diseases affect not only the patient, but the family, the community, and our great state of Connecticut. So please, whenever you hear me talk about numbers, know that that's a person, that's a child, and that's an adult behind these numbers. Both of the diseases I will discuss involve eosinophils. So what are eosinophils? Eosinophils are a special type of white blood cell that helps your immune system to fight certain infections and diseases in the body called inflammation. While white blood cells can protect you from getting sick, if your body produces too many eosinophil cells for too long, that can lead to other problems. So I believe my first slide talks about EGPA. EGPA, and the pronunciation of it is there for you. And believe me, it takes a while to pronounce these words. But EGPA is classified as a rare disease, also affecting approximately 5,000 individuals. Originally named the Church-Strauss syndrome in 1956, after two physicians named Dr. Church and Dr. Strauss identified 13 patients with similar symptoms. The disease was renamed eosinophilic granulomatosis, see, told you it was difficult, with polyangiitis in 2012. If we talk about the demographics of this disease, the average age of onset is 35 to 60 years of age. EGPA affects a similar proportion of men and women, and there is no ethnic predisposition that has been clearly demonstrated. On average, it takes about 4+ years between disease onset or symptoms and the actual diagnosis for a patient to be diagnosed with EGPA. The burden of this disease is that it is rare, it is multi-system disorder that predominantly affects the small and medium-sized blood vessels and is often characterized by asthma, eosinophilia, and necrotizing vasculitis. It is a rare disease that occurs when certain types of cells in your blood or tissues inflame. That means they swell or they become swollen. And it can be difficult to differentiate from other diseases. The inflammation can affect many organs, including your heart and your kidneys. And the cause, unfortunately, of this inflammation is unknown. The EGPA journey is classically described as a 3-phase disorder. However, these 3 phases do not have to be in sequential, and they may even overlap. Patients may not experience all 3 of the phases. There is an allergic phase, which affects the lungs, and oftentimes these patients are presented with a diagnosis of severe asthma. There is the eosinophilic phase, in which there are elevated eosinophils, continuing with lung involvement, as well as the possibility of heart and the GI system involvement. And then there's the vasculitis phase, where there is inflammation in the walls of the blood vessels. Each organ system can present differently. There are a number of different tests a patient may encounter along the diagnosis journey and along the disease journey. Disease remission is the goal, where the symptoms are minimal to non-existent. Many individuals have greater than 1 disease relapse, and relapses can impact patients in many different ways, such as increased costs, significant healthcare use, and a heightened risk of permanently body damage or organ damage. Patients have also reported impairments in their quality of life. And if we could go to the next slide, please. So what is HES? HES, or Hyper-Ecenophilic Syndrome, is a group of rare blood disorders that occurs when the blood has very high numbers of eosinophils. Again, approximately 5,000 people in the US are diagnosed with HES, and it may affect patients of any age or gender. Majority of the patients have an onset between the years of 20 and 50 years of age and affects slightly more men than it does women. The initial presentation and diagnosis, patients with HES may initially see a primary care physician, a specialist, or may be seen in the emergency department hospital, depending on their symptoms, For example, a patient with an itchy skin rash or hives might decide to see a dermatologist or an allergist. A patient with difficulty breathing and chest discomfort may be referred to by their primary care physician to a pulmonologist. A patient with severe gastrointestinal pain may be in the emergency department and they may be referred to a gastroenterologist. A patient with fatigue may continue to be seen by their primary care physician or perhaps someone in the immune system. Patients can present to the healthcare provider or to the emergency care facility or to the emergency room with either acute or chronic symptoms. So as you can see, the burden of disease is great. The time to diagnosis is challenging because the heterogeneity of the patient presentation lacks, and the lack of understanding of HES among specialists and inconsistent referral of patients between their primary care physician and other various specialists. The treatment plan will be different for everyone. However, the treatment goal, although it may affect everyone differently, the goal is to reduce the number of eosinophils circulating in the blood and in the tissues and help prevent damage to organs. Living with a chronic condition can be difficult, not only physically, emotionally, and financially, not only to the patient, but to the caregiver, to the family, to the community, and to our state. I, Arnita Christie, want to thank you for your attention as I shared information about these two rare diseases, HES and EGPA. GSK is committed to providing education to patients, caregivers, and the medical community regarding rare diseases that affect the populations in these rare disease spaces. I also want to, of course, thank the Connecticut Rare Disease Network. And I know she doesn't want the recognition, but we have come so far because of the work of Leslie. Leslie, thank you. Thank you for fighting the fight. Thank you for having us to accentuate our stripes. Thank you for your selflessness and your tiredness. We in Connecticut are grateful to have you. Thank you again, everyone, for this opportunity.
Thank you, Arnita, and to GSK and your team and all the affiliates and all of our sponsors. It's beautiful to see this collaborative process transcending all of the different experiences that we all represent, from patient to provider, to those in pharmaceuticals, and certainly all of the collaboration that we've seen thus far with our state legislature as well to help all of us live a better life. Next, I'd like to introduce Liz Duffy. She's a parent of a child with a rare muscular disorder and director of alumni relations at Greenwich Country Day School, board of directors for Cure Rare Diseases, and she's going to speak about the challenges that her family is facing. Her second child was diagnosed with DMD 2 weeks before his second birthday. Liz?
Amazing. Can everybody hear me?
Yes.
Oh my gosh, this is perfect timing because I have a call in like 10 minutes. So do you have my slides maybe? Or, oh
there
yeah,
they
there
are.
he is.
Yeah.
So this slide serves no other purpose than to show you how adorable this child is. This is my little Ned Duffy, also known as Baby Yoda. He, as you just heard, he is 4 years old. He was diagnosed with Duchenne muscular dystrophy 3 weeks before his second birthday. I had absolutely no idea what the disease was. I had no idea this would ever impact our lives. It was absolutely heartbreaking and sort of this earthquake that we never really imagined. So after his diagnosis, we spent a little bit of time sort of sheltering in place and huddling together and sort of trying to figure out what this meant. And that took about 6 months. And during that time, we collected all sorts of people. We collected doctors, we collected energy healers, we collected therapists. I mean, anybody who would sort of be on this journey with us. And of course, in addition to that, an amazing rare community. you know, of course, it's a community, it's the party you never really wanted to be invited to. But here we are, and we've definitely found some meaningful connections within it. So, and I should have said at the start, this is my first time doing anything like this. This is relatively new to me, and I do try to balance sort of the focus that I have being present and with my family, between sort of doing all this other things. But at the sort of chance to advocate for him, I couldn't pass this up. So if you could just switch the slide really quickly, I won't go too much into what Duchenne is. And I remember sort of when people started talking about that to me, I refused to even recognize the name. I mean, I sort of did not even want to know how it was said or how to pronounce it, and I sort of brushed it under the table. But now it's a name that sort of is constantly in the back of my head. So there are bullets here. I won't bore you with them. I know you all can read through them, and I'm sure you all know what it is. It's a progressive muscle wasting disease that is a life-limiting diagnosis. So most boys with DMD live until you know, their mid-20s, early 30s. And so basically the muscle that Ned is born with right now is the muscle that he has. And over time, it will just break down. And so it's sort of this slow, terrible process of watching your son lose his abilities. So right now, there he is. Again, no other reason than he's just cute. But it is, he still moves, he still walks, he's still happy, but he is now beginning to complain about his muscles being sore. He doesn't really understand what that means. It makes him really angry. If you could go back up. So he fatigues really quickly. He has challenges with stairs. It's now sort of, as I said, he has behavioral concerns, and I think it's largely because he's super frustrated. And I know every mom says this, but I think he's the sharpest tool in the shed, and he gets it. He gets that he can't do that much, and he's acting out, and that's really sad to see because he can't conceptualize it, and so that's hard. And now he's beginning to understand he can't run as fast, and he can't keep up, and he doesn't understand why he can't play hockey.
My car or yours?
Somebody's carpooling. But he's amazing. And then the next slide. So this is, you'll see my cute family. We have an 8-year-old daughter as well. And as I said, this was really earth-shattering for us. It just wasn't on our radar that this could be something that happened. So we spend a lot of time trying to focus on our little family and our extended community. But in the meantime, really working hard to do stuff like this. So I've joined the Board of Cure Rare Disease, which is an organization based in Boston. It's working to develop customized treatments. So right now, DMD has no cure. It has some treatments. They aren't terribly effective. Everybody sort of admits that. We're looking to find a cure. And so this is customized drugs to really get to the genetic problems of these boys. So DMD is part of a genetic coding error. And we're looking to fix that. We also started our own fund, and really that's based on research. Admittedly, it sort of gave us an outlet, a powerful outlet to channel some of our community support. But I would say the reason I'm here now is because this entire disease, on top of course, being this emotional, overwhelming heartbreak, there is a logistical and tactical challenge. I am constantly talking to insurance and battling things that are just shouldn't be battles, right? It should just be very easy. I work full time. I'm struggling to do his PT appointments. Luckily, I have an amazing set of parents who help. And the significant financial burden. He does aquatic therapy. It's not covered, but he loves it and it's his thing. And, God forbid we take away an activity that he can do. It's just not, that's off the table. He has braces and sort of orthotics and all these things that cost money. And we're fortunate, we are, but at some point, this is going to be a significant burden. And I'm not naive to think that it's not even going to get, it's going to get 10 times worse. He's going to need a wheelchair. He's gonna need lifts. He's gonna need all these things that, again, I just sort of don't go there yet. But we try our best to do as much as we can and go outside and be happy and give him the best life, and really not to sort of ever lead with this diagnosis. But I think that the best outcome for what we can ask for our sort of larger community and the rare community and our state and all the people that are here to support us is just support with insurance, advocacy, knowledge, support for caregivers. And that's sort of really it. But at the very least, I just wanted to show you this adorable child who was dealt this crummy hand of cards. And to the extent that we can make his life as wonderful as possible, that's where I'll lean into this process.
Thank you, Liz, for your courage and for mothering your beautiful boy. I, for one, as a parent of a pediatric patient, know well some of those hurdles and barriers to accessing the supports that we need, and sometimes rather simple things that private insurance companies, because of some random and small footnote somewhere, find reason to deny coverage for. And along these lines, it's my pleasure to introduce another ally within our state legislature in the person of Senator Julie Kushner. She has been an ally to me personally in our family's journey. I'll never forget an incident where, with the handicap placard in my wife's minivan and not in my car, I was almost ticketed at our school. And little did we realize that there was some legislation that passed earlier in that year that only gave one handicap placard to a family. And with Senator Kushner's support and some other state legislators, it made its way as an amendment into a transportation bill at the end of a legislative session. And now families with children 18 years or younger are eligible for 2 handicap placards per household. So didn't want to necessarily bring that up, but it just so happened that I saw that State Senator Julie Kushner's with us. So Senator Kushner.
Thank you so much, Father Nick. And it is my privilege to be here today representing the 24th District, and Father Nick and his family are constituents of mine. And I remember the day I met you at the Greek Festival, and it opened up this whole world of issues that I was unaware of. And I am very privileged to serve, and I take it really seriously to make sure that all of our residents and their needs are addressed. And so that's why today I signed on as a co-sponsor of 5260. And, I am a member of the Public Health Committee, and I will advocate strongly there that we establish the Rare Disease Advisory Council, because I know it's something we should have done a long time ago. And it's past time to make sure that we have an advisory group that is really helping us to understand all of the needs and the issues confronted by families in Connecticut who have a member of their family that has a rare disease. And so I really appreciate everything you're doing. I wish I could have been here for the whole presentation. I learned so much from you. I am on 2 public hearings right now and have a 3rd that's going to start this afternoon. And that's just the way of the legislature at this really busy time of year. But it's an important issue, so I didn't want to neglect it. And I will post today about it as well. So I'm honored to be here, and I appreciate all that you're doing.
Thank you, Senator Kushner. We appreciate all your help and support.
Thank you. I know Dom is here too, and so I want to say hi to Dom. Dom is always posting and keeping me notified as well. So thank you so much. Thanks so much. I'm going to head back to my hearings now.
Thank you again for all of your advocacy for our community.
Take care.
Senator Kushner. Bye-bye.
Thank you again, Senator. It's my honor to introduce our next speaker, Amy Trickles, the Director of Programs at the ALS Association Connecticut Chapter. She will be speaking about the needs of Connecticut residents living with ALS. Ms. Trickles, the stage is yours.
Thank you so much. First slide, please, and I will go very fast. ALS is also known as Lou Gehrig's disease, and it is an always fatal neurodegenerative disease in which a person's brain gradually loses connection with their muscles. People with ALS gradually lose the ability to walk, talk, eat, and eventually breathe. Although there are a few outliers, like Stephen Hawking, most people only live 3 to 5 years after they have received an ALS diagnosis. Next slide, please. There is no proven cause of ALS, there's no cure, and there are only a few drugs that are approved by the FDA for treatment. About 10% of ALS cases are inherited through a mutated gene, and genetic testing is available to families of those diagnosed with ALS, but not everyone wants to test. Veterans of all branches of service are twice as likely to develop ALS, and a recent study showed that NFL players are 4 times as likely, which helps us hopefully lead to some causes. ALS is unfortunately often diagnosed by ruling out many other diseases, which may take months or years. ALS is mainly diagnosed in older adults, but we currently serve someone who just turned 21. Due to the very rapid progression of the disease, most patients need quick access to very expensive equipment and care during their time living with the disease. Next slide, please. Last year, our organization here in Connecticut served 381 people living with ALS. Our PALs are seen by individual neurologists around the state, but concentrate mainly at the Hospital for Special Care in New Britain, the Yale University Care Center, and the Veterans Affairs Hospital in the New Haven area. Due to the high cost of this disease, our nonprofit focuses on providing loaned medical equipment, access to accessible transportation, support groups, and other resources to both patients and caregivers. Like everyone with a rare disease, our PALs struggle with insurance coverage, access to care, availability of home health care staff who also understand ALS, staying in their homes as long as possible, and the need for continuing research into causes, treatments, and a cure. In fact, on our call right now is Ben Mathis, who hopefully he can give a wave. Ben is a veteran who was diagnosed in 2015, and he's one of our shining stars in our ALS community. A rare disease does not just affect the patient and their caregivers. It's a community of their friends, their coworkers, their medical providers. It's their 3rd grade teacher who donates to research every year. It's their cousin who walks in a 5K in their honor. All of you listening are part of this rare disease community, and a Rare Disease Advisory Council gives everyone a greater voice. Thank you so much for your time.
Thank you, Amy. We are always grateful to hear from as many of our families and those who are caregivers. I'm not sure that Greg is on right now, so we might advance the slide so that we can hear from our next speaker, Kelly Cummings, who is parent of a child with a rare genetic disorder, AGT-PBP1. It's essentially a pediatric form of ALS, so it's it fits with what we just heard from Amy, and she's going to be talking about, in particular, Stripe Out Your School Day at Joel Barlow High School in honor of her son, Tyler. Kelly?
Thank you so much for having me speak today about my son, Tyler. Tyman Cummings was what he was known as and still known as. I'm here with my daughter, Casey Cummings, his sister. You know, I'm an educator in the state of Connecticut and also a school counselor in a middle school. I'm very grateful to Leslie because, you know, as a mom that's lost a child, it's difficult to speak about our journey and everything that we've been through. So I know I have a fellow parent on here cheering me on right now. So to get me through this presentation. So next slide. I think there's, oh, okay. So Tyler was, at the time of his passing, he was the oldest child to ever live in the world with AGT-PBP1. Leslie and I like to refer to it as a juvenile ALS. He was 17 years old when he passed away, July of 2019. At the time of his passing as well, there was only 13 known cases in the world. There were only 2 children in the US, and we still have Sadie that is thriving in North Carolina at this time. And so it's been a very lonely journey. But, you know, hearing Liz's story, Liz Duffy's story really resonates with me. And what she's going through right now. But it's a rare neuromuscular degenerative disease, as you know, I said. There is no cure. There's limited treatments, and we were told from the National Institute of Health that we probably would not see any cure within even our lifetime or Casey's lifetime of living. Tyler was deeply loved by many of his friends, families, peers, and all of that. Tyler was born just like any other child, met normal milestones, loved to swim, and then took a quick progression. As Amy explained, once you're diagnosed, you usually live for, for us, it was 2 years. But yes, the 3 to 5 years. Next slide. So when Tyler was younger, we learned through an MRI that he had a form of CP ataxia, which was a misdiagnosis initially, but we were referred right away by our pediatrician, Dr. Homa, who sent us to Boston Children's Hospital. He did a lot of research around, ataxia, and thought that was the place to go. But I know Dr. Rubin, I'm assuming, that we, our doctors at Boston Children's also consulted with the Children's Hospital here in Connecticut. So hopefully they cross paths at some time with the work that they had been doing with Tyler. We were told all of this genetic counseling would not be covered by insurance. And it was tens of thousands of dollars later, and we still didn't have an answer. Years go by, Tyler's disease continues to progress. And, thankfully we had Dr. Ghosh at Boston Children's Hospital that finally got Tyler into a research study at the National Institute of Health. Our whole family, my husband, Steve, Casey, Tyler, myself, spent a whole week there going through tests. And then about a year later, that's when we were learned that Tyler had this disorder, and we were just giving letters as the name of the disease. So he's continued, our family continues to be followed by the National Institute of Health. So that advocacy by our medical providers that have been speaking today for families like ours really helped us get the answers, but it wasn't the answers that we wanted. We were grateful for our medical professional teams. Next slide. So, I did want to talk briefly about the family impact of a rare disease. I know it was mentioned by Hunter. I'm your biggest fan right now, to speak about the educational piece, how difficult it is for rare disease children to obtain the services that they need within the school setting. I think I had an advantage being, working in the school systems, and why I fully support educators with their with how they work with children with medical needs and things like that. I do know the journey to get there is very difficult because of the complexities of all of our children's rare diseases. Obviously, as well, the financial toll that it's taken on our family has been very significant. We've done a lot to try and get through this, but it's been difficult. We worked hard to try and obtain and have Tyler become eligible for state services like DDS services. Boston Children's eventually hired an advocate for us through a grant that they had while Tyler was hospital up at Boston Children's for about 6 months before we brought him home to end his life. And the day that we signed Tyler up for hospice was the day he was given DDS services. So it's a long fight and battle to get the things as rare disease families need. Obviously, I'm still very impacted by my grief, along with my daughter Casey here. It's a very difficult road. I'm sorry, I was trying to get us promised I was going to keep it together. But Tyler's legacy, so that's really what I was supposed to talk about. But we started the Stripe Out Your School event. I connected with Leslie and Kristen when I was living in Boston. Tyler was hospitalized, became more familiar with the National Organization of Rare Disorders. I One of the downfalls of our journey was we weren't connected to them sooner. So we made it our mission to bring awareness to the National Organization of Rare Disorders through Tyler's legacy. And so we do that through the Stripe Out Your School event, and I'm going to be calling Hunter to get his school to do it as well. But the year after Tyler passed, February of 2020, we kicked off the Stripe Out Your School event. We got Connecticut social media influencers, young social media influencers to help us kick it off. It ended up going nationwide that year, where schools were striping out students, parents, family. The purpose is to educate our young children in the state of Connecticut and nationwide on rare diseases, because they are our future. They are who are going to hopefully go into the field of medicine and research and all of that. And that is our mission. And we'll be doing that on Monday. And it was co-founded by Joe Barlow High School and Roger Ludlow Middle School, where I work. And it's just a wonderful event. And we're so excited that we can remember Tyler in that way. Thanks so much.
Thank you so much, Kelly. Your story was very moving, and thanks again for coming and sharing yours and Tyler's experiences. He will be missed. I'd like to move on to our next speaker, who is Phil Morella. He is a parent of 2 children with a rare genetic disorder and the founder of Dana's Angels Research Trust, or DART. This organization raises funds for research on Niemann-Pick type C. Phil, the stage is yours.
Well, thank you very much, Hunter. And I really want to thank everyone that's on the call. I want to thank Leslie and our Lieutenant Governor and our state representatives. This is also very, very, very important to the families, and I certainly want to thank all the families, and caregivers, advocates that are sharing their stories. I'll tell you a little bit about our family journey, our foundation, our wonderful NPC community, and some of what we're doing, and try to be as quick as I can. Our journey started almost 20 years ago. In some respects, you could say more like 23 to 24 years old, when our daughter Dana, about the age of 5, was showing, after being a perfectly normal child, showing some severe developmental disabilities, primarily with her balance and learning disabilities. And that started us on what I always said was a 3-year and 5-minute journey to get a diagnosis, because no one seemed to be able to figure out what was wrong with Dana until we got to a particular neurologist, Dr. Mark Patterson, who was at Columbia University at the time, and being very familiar with the disease, he knew exactly what she had right away. One of the scariest moments in your life is when someone tells you your child has a rare degenerative fatal disease, and there's no treatments. And so shortly after, we started Dana's Angels Research Trust in 2002, and we've been working with the incredible NPC community on funding research. And I have to say, in many respects, compared to some other rare diseases, we've had a lot of challenges, but some success as well. Our family journey starts with Dana, and with Dana getting sick. We had 4 wonderful children. Dana was our second oldest. We had 2 girls and then 2 boys. And I have to tell you, the disease it's a whole body disease. It's a cholesterol storage disease, but it's primarily manifested neurologically. So you have this neurodegenerative disease that just starts taking each of the child's abilities piece by piece. One of the things that we've tried to explain, for example, to the FDA, is that there's something a child can do today, and then all of a sudden there's something that they can't do tomorrow. They lost some neuron someplace that just literally took something away from them almost overnight. And it's just terrible to watch your child, fall apart day by day. And so Dana, although say seemingly normal at 4, was in a specialized walker by the time she was 9. She was in a wheelchair by the time She was 11. By the time she was 12 or 13, she had a feeding tube and got all of her nutrition that way because of dysphagia and other swallowing issues. We had to worry about, aspiration pneumonias, which she managed to get anyway. She was in the hospital, it seemed like every spring for 4 to 6 weeks with a pneumonia from about the age of, 14 on. And at the end of the day, I mean, Dana was in a specialized wheelchair. She had 24/7 care. We had difficult times with the school system getting her some of the needs that she needed. At the end of the day, she had a trach and a respirator, as I said, 24/7 care, and seizures. And she died just 11 days shy of her 20th birthday, which in some respects, even those difficult years were a blessing, because when Dana was diagnosed at age 8, we were told the most we had left with her was 4 to 5 years. And that's very typical for Niemann-Pick children that are diagnosed. We do have adult patients as well, but that's more rare. With some of the experimental medications that Dana's Angels Research Trust was able to help get started into trials, we had those extra years with Dana, as difficult as they were. The second real challenge that happened for our family was that 2 years after Dana was diagnosed, our youngest Andrew was diagnosed as well. And I'd like to bring up, the importance of newborn screens, because early intervention is so important for these patients. Andrew was able to start on our first medication, Zavesca or Miglustat, at the age of 5, whereas Dana was 11 and already in a wheelchair. So Andrew benefited greatly from that medication. It certainly has helped slow the progression of the disease. That leads to one of our other challenges that I'll talk about, which is that it's a drug that's approved everywhere except the United States because of the FDA and the way they operate. But, Andrew has benefited from that. He's also been on another one of our drug trials for medicine for about 8 years now. He's a real trooper. He's a hero, I think, as many of the children are. This drug is a miracle drug. We're still fighting for approval with the FDA, but it's delivered via spinal tap. So Andrew's been getting spinal taps either twice a month or once a month for 8 years now. He's had 135 spinal taps. And we've had that at the NIH. We've done them out at Lehigh Valley at one point. We've been to Rush Medical Center in Chicago, as well as Montefiore Children's Hospital in the Bronx for a while. But we're very delighted, and I want to say a special thanks to Dr. Lawrence Hirsch at Yale, because we now have an expanded access site at Yale, so that Andrew can go up to New Haven instead of someplace much further. And so many of the children have to go to Chicago to Rush that, we're very honored as a foundation now to be sponsoring some additional administrative help up at Yale so that they can expand the access site. So we're actually going to be able to treat other patients at Yale from the Northeast now. And there are potentially 3 patients from down in the Philadelphia area and a young child up in Massachusetts that will hopefully no longer have to travel to Chicago once or twice a month, but they'll be able to go to Yale. So DART is honored to be able to working with Yale and bring a treatment site here to Connecticut. As I said, we started DART a little while after Dana was diagnosed. We work with an NPC community that is incredibly collaborative. There are families raising money with family-founded charities across the country. DART, being here in Connecticut and Fairfield County, is one of the larger fundraising organizations, but it's still a real community-wide effort. Niemann-Pick type C is often referred to as children's Alzheimer's. One of the difficult challenges is the dementia that develops. I mean, Andrew is 22 now, but if you ask him how old he is, he never says 22. He'll say 17. He has, much like an Alzheimer's patient, movies that he likes. New ones are difficult to introduce to him. There's just a comfort factor that comes, if you will, with a dementia. But at the same time, whereas Dana had lost everything by the time she was pretty much 15 or 16, Andrew still talks. He can still walk with assistance. Likes to joke around. He can still read. He can still do some mental math. He can spell. These are things that are just wonderful miracles for us, and we're just delighted that we've been able to help bring some of these therapies forward. The challenges, everyone's heard the challenges of raising a child with a rare disease, all the medical costs, the things that are not covered by insurance, fighting with insurance, as a community, fighting with the FDA. I actually want to thank, the Representative Himes and Senator Blumenthal and Senator Murphy, because they've helped bring some awareness of our challenges to the FDA. And we've had some more helpful dialogues with the FDA than in the past as of late. But there's also challenges on the state level. I mean, Andrew has a neurodegenerative disease. His IQ right now is about 55. And yet we're fighting with DDS over whether Andrew qualifies for services with an intellectual disability. And some of that comes to what, the RDAC hopefully will be able to do with our school systems. I mean, if someone had told us to have a IQ test right before he turned 18, we wouldn't be in this battle. If DDS recognizes neurodegenerative diseases, we probably wouldn't be in this battle. But it's what we do as patients. It's what all of us are doing. And, it's just glad to be a part of this rare disease community that fights so hard for their children. In Connecticut, what's interesting is, rare as Niemann-Pick is, and it is an ultra rare disease, we probably only know of about 200 to 250 patients in the country, maybe 600 or 700 in the world. Over these years with Dana's Angels Research Trust, we've known 8 patients in the state of Connecticut, 6 families. And we have watched, 5 of those, beautiful children pass away. And I know Barb Lazarus is listening here today, and she has 2 wonderful sons. They're older, but this is our journey, and this is our fight, and this is our community. And it's a rare disease community fight as well. And so I thank everyone who's participating, everyone who's fighting for their children. And I think if we fight together, there's an awful lot that we can do. And I thank you very much for your time.
Phil, thank you so very much for sharing such a complete picture of what you and your family have been through with respect to your rare disease journey and your children's rare disease journey. I think all of our hearts go out to you for your loss and for what you've had to endure, you and your children. So thank you so much for being so forthcoming. Next, we have another speaker whose name is Greg Polletti. He is the parent of a child with a rare cancer, and he is the founder of the Golden Lights Foundation. This organization raises funds for cutting-edge research on pediatric cancers. So Greg, if you'd like to say a few words, we'd love to hear from you.
Hi, everyone. Can you hear me?
Yes, we can hear you.
So I apologize. I'm actually trying to get into the office right now, but I wanted to just say a few words. Thank you for everyone for letting me, share our story and talk about, pediatric cancer, which, as everyone knows, is by definition rare. But I'll briefly talk about, my history. About 3 years ago, my daughter Willa was diagnosed with neuroblastoma. In short, she basically complained of having a stomach ache, as many children do, and thankfully my wife and I, were listened to her and didn't brush it off. And our pediatrician basically, I back up. She complained of this stomach ache on a Saturday. And by the Monday, we brought her to our pediatrician, and that morning, and by 1 o'clock in the afternoon, we were at MSK, Memorial Sloan Kettering in New York City. That experience, so first of all, we didn't leave the hospital for about 25 days. And, Willa went through all the treatments, through chemo, through surgery, radiation. And what we quickly realized is everything that Willa went through and that we went through was experimental. We were on more trials than I can possibly think or remember. But there wasn't a specific protocol for children who are living with high-risk neuroblastoma. But even further, for all the other children and families that we met at MSK as well, it's pretty much, they have, the chemos that were developed 50 years ago, and they're trying and scrambling to do trials for other experimental drugs at that particular hospital. One thing I want to state before I move on about Golden Lights and our mission is that with these experimental and these trials, you are kind of left to the expertise of your doctors. And if you don't happen to be lucky, like we are, living so close to New York City, you might be at a hospital who has maybe seen the pediatric cancer or neuroblastoma or whatever it is, maybe once or twice in their professional career. So being able to fund research and get therapies to market is really, really important for all rare diseases, and especially pediatric cancer. Now, as far as Golden Lights Foundation is concerned, our commitment is to provide opportunities for donors to directly fund the projects and people that are curing pediatric cancer. And we seek to find a cure for pediatric cancer through funding specific cutting edge research, as well as building close relationships with the doctors who are thinking big. They're not thinking about their particular children at the hospital, or as they always are probably, but more like, how can we impact the largest amount of children and have a breakthrough. One of our primary goals is to take the giving process and basically simplify it and illustrate it, so any particular person who wants to support the cause can understand exactly where their donation and how their donation is being used, from the specific doctor research who is running the project or trial to the specific tools or equipment needed to carry out that particular trial or project. We basically want to try and illuminate and give power to the people who are supporting us, as well as the processes that are fundamental in curing the cancers and affecting children. Last thing, and I'll wrap up, is, I think as Liz Duffy spoke earlier, insurance is something that we have seen going through our process, that if you're not lucky enough to have a hospital that can kind of help you navigate it, it is truly, truly a really difficult process. And you have to be really savvy, or you have to have a hospital that doesn't want to put it on the parents and basically tries to take care as much as they can for the parents, and then you have to kind of get over the finish line. But again, our foundation is really hyper-focused on simplifying the giving process and making sure that the biggest cutting-edge projects that will have the most impact will be available for as many children as we can affect. Thank you.
Greg, thank you so much for sharing your perspective and for just discussing with us your foundation and everything that you do in the rare disease community. It's my pleasure now to introduce.
Excuse me, Katie. I just want to remind everybody we have to be off by 11:15. So please make your comments brief at this point, just so we can get to everybody. I apologize for the length of the agenda today. If you've cut out, please let me know. Thank you.
Thank you, Leslie, for the reminder. It is now my pleasure to introduce Courtney Assad, who is the Director of Outreach and Development for Hope in Focus, which is an organization that is dedicated to helping those with Libra congenital. Oh boy, she can explain how to pronounce that. It's LCA, which is a rare inherited retinal disease. Courtney, please go ahead.
Good morning. Thank you for having us this morning. I'm excited to have joined the Hope and Focus team. You probably know us as Sophia Sees Hope, as we were for the past 7 years. Before this year, we recently rebranded. We help with the wider Libra congenital amaurosis community. So I'm proud to now be an advocate for rare disease. For the past 8 years, Hope and Focus has been dedicated to generating awareness, supporting affected families, and raising funds to advance research for diagnosis, treatments, and cures for blindness caused by Libra congenital amaurosis and other rare inherited retinal diseases. Libra congenital amaurosis, known as LCA, is characterized by severe vision loss at birth. While some children are born with little or no vision, others may have significant vision loss within their first few years of life, stable vision for a period of time, and then eventually complete vision loss as the retina deteriorates into total blindness. It is a degenerative disease. More than 27 genes are associated with LCA, and a mutation in just one of those can result in blindness. LCA is estimated to occur in about 1 in 33,000 people, and this represents about 108 based on Connecticut's population. If you could go to the next slide. Some facts about LCA there. After decades of research and dedicated investment in studies, scientists created a groundbreaking genetic therapy that helps restore vision in patients with one of the genetic mutations causing LCA, which is RPE65. In 2017, the Food and Drug Administration approved a treatment developed by Spark Therapeutics called Luxturna, which is also the first genetic therapy in the United States to treat any rare inherited disease. Meanwhile, genetic diagnosis alone remains a significant challenge for many. Individuals living with this disease need to confirm their genetic diagnosis so they can better understand and prepare for the progression of the disease, including in some cases, life-threatening conditions like kidney failure as one example, in addition to their vision loss. Confirmation of the genetic diagnosis also allows individuals to support the advancement of research into treatments and be available for treatments where they exist. To date, Hope and Focus has contributed more than $140,000 for this vital resource of genetic testing and counseling for patients, as it is not often covered by insurance. If you could go to the next slide. Hope and Focus has also raised and donated more than $335,000 to fund genetic retinal research. There are many gene-based clinical trials targeting several different genes, as well as retinal cell therapy trials in progress. There's many different methods in which we can attempt to treat these genetic mutations. Unfortunately, each genetic mutation does require its own treatment. So the process of drug development is necessary for each one of these individual mutations, therefore lengthening the process. LCA patients, though, that were treated with Luxturna experienced dramatic changes in their lives with greatly improved or restored vision. 5, 6, 7-year-old children treated with Luxturna view life in a new light in big and little ways. They can now see rainbows arcing in the sky and stars shining at night, and the optimal window for reversing vision loss is during the early phase of the disease before it degenerates. Current clinical trials and preclinical research give hope that to those with one of the 26 other gene mutations identified to cause LCA. For us, research is critical to advancing treatments for LCA and other rare inherited retinal diseases. When Luxturna was first introduced, however, several states attempted to pass laws to deny access to treatment to individuals, stating that a certain degree of blindness must be met before they could access treatment. Restrictions like these are really unacceptable for our community and go against federal health recommendations, which state that the earlier the intervention, the better the expected outcome prior to that vision loss. No one who qualifies in order to the FDA guidelines should ever have to wait to be blind enough to receive access to treatment. Hope and Focus, along with other organizations, were quick to call these states out, and we urge the Connecticut General Assembly to also support patient access to FDA-approved treatments. I believe that RDAC will also help with the education around these treatments when they do come to market. When treatments are available and accessible, it impacts not only the quality of life of the recipient, but there is also a positive economic impact for them and to the state. The reality is those living with vision loss very often require additional support services from government safety nets, as they're more likely to experience difficulty finding work, issues of loss from independence, and to physical accidents and mental health issues. Here at Hope and Focus, we strive to keep hope at the center of our messaging so that we can together make vision possible for those living with LCA. We're thankful you've taken the time to listen and start to understand the complexities around rare disease and access to treatments and services for our community. Thank you.
Thank you, Courtney. I am grateful for the work and remember being at the Legislative Office building a few years ago and getting to know at that time Sophia sees hope, and it's beautiful to see that work continuing, and we appreciate all that you do. I want to next introduce Paul Pescatello, Senior Counsel and Executive Director of CT Bioscience Growth Council at CBIA. He'll be talking about rare disease business in Connecticut and industry. Paul?
Yeah, thank you so much. So it's great to be with you all today. Again, my name is Paul Pescatello. I oversee the Bioscience Growth Council at the CBIA, and the Growth Council is all about growing the biotech sector, and especially biopharma, life sciences, research and development. Virtually every member of the Bioscience Growth Council, which includes emerging biotechs and larger legacy pharmaceutical companies and research institutions, virtually every one of our members is involved in rare disease research in one form or another and has contributed in some way. So rare disease research is a lot of work. If we could show my slide, it takes about, this is a slide showing the costs and the time it takes to bring a new medicine from idea all the way through to FDA approval. So it could take up to a decade or longer, and $2.6 billion. It's a lot of work, and it's a lot of work whether it's a rare disease or not a rare disease. We always stress when I'm talking to legislators and policymakers, it's important to do rare disease research. Obviously, for rare disease patients, a great need is, I think as Senator Haskell pointed out, rare diseases individually are rare, but they're not rare. There are many of them. So doing that research is critical to the rare disease patient population, but it's also critical for the non-rare disease population. We always try to stress that the rare disease research, the investment in it pays huge dividends for the population generally. So whether it's rare genetic disorders, rare blood disorders, rare cancers, all that research and all the other rare disease research informs and brings solutions to much wider patient populations as well. We'll close on 2 points. Again, it's really important to understand the investment and research arc of life sciences research and development. Again, the time and costs involved. The companies, the research institutions that do this important work, they have to be confident that they can recoup this huge investment. It's very different from other types of businesses, other types of research efforts. So, for example, an app for your cell phone might be $200,000 to develop, whereas again, $2.6 billion for a new drug. The last thing I want to mention is HB 5260 to set up a Rare Disease Advisory Council. We are very much in favor of this. We'll be advocating for it. The bill just came out. We'll be there for the public hearing to advocate for it. It's important in many, many respects to bring focus to the rare disease community, but also on some specific issues. I think especially it will be helpful in terms of making making it clearer the very complicated diagnostic arc for rare disease patients and help legislators come up with better policies to help the rare disease community. So with that, thank you very much for this time to speak.
Thank you, Paul, for coming and sharing your insight. Thank you for supporting the rare disease community. So I'd like to welcome our next speaker, Candace Floridi. She is a parent of 2 teenagers living with PKU. She'll be talking about the difficulty of paying for her teenage children's formula. Candace, thanks for coming.
Hey, thanks for having me. Hello, and thanks. I've edited this down, I think, to a minute. So Leslie, I think I'll be all right. Thanks for participating in this year's Rare Disease Day. I'm very happy that you're all here and very proud of our General Assembly, women and men, for taking the time to learn about this. We live in Norwich, Connecticut, and our 2 teenagers, Marguerite and Henry, are thriving in spite of having phenylketonuria, also known as PKU. To simply describe PKU, this is a metabolic disorder that causes debilitating and irreversible brain damage if left untreated. A person with PKU may only digest a very tiny amount of protein every day, and in order to thrive, patients must drink a prescription formula to supplement protein lacking in their diet. PKU requires a very restricted but achievable low-protein diet for life. Marguerite and Henry are patients of Dr. Joseph Tucker and the metabolic nutritionist and our superhero, Sherry Gray at UConn. Our children are the happy result of the research and development and good governance that came before us. Marguerite's 16 and a junior at NFA High School in Norwich here. She's in the Honor Society and is a big nerd. She has a GPA of 4.16 and is on the fencing team. And Henry, who's 13, is every bit the nerd that his sister is. He's an outstanding student studying at Integrated Day Charter School. And he's also a student of the Southeastern Connecticut Chinese School studying Mandarin and math. Their achievements would not be possible without the devotion to their rare disease by doctors and researchers and even the legislators who came before them. But paying for care can be as painful as many of the symptoms of our rare diseases. In spite of Connecticut's state mandate, it takes diligence, lots of good questions, and mostly time to figure out how to pay for the minimum standard of care for a patient with PKU. I'm going to stop there so other people can speak, but thank you for continuing to watch out for us and for making yourself aware of your rare disease community here in Connecticut. Thanks.
Candace, thank you so very much for sharing your experience with rare disease and, your families as well, of course. We're coming to the conclusion of our event today. And so in the interest of time, I'll introduce our final 2 speakers together. I've had the personal privilege and the honor of serving on the Rare Action Network with both David Leeds and Dan Donovan. David will speak first, and he is a rare disease patient with hereditary angioedema with normal C1 inhibitor. And he's going to share his experiences on access and affordability of rare disease medications. And then after David, Dan Donovan, who is the founder and CEO at Rare Life Solutions, will also say a few words. So David, please go ahead.
All right, thank you, Katie. So in the essence of time, I will give the short version of what I was going to talk about. But I am a rare disease patient with hereditary angioedema with normal C1 inhibitor. I've actually had the privilege of speaking at the last couple of Rare Disease Day events, previously spoken about my journey to diagnosis and about my challenges of actually being a hospitalized patient with a rare disease. Today, I wanted to touch on what has consumed the last 6 months of my life, which gets into the access and affordability of medication. So I'm sort of lucky, if there's any such thing in the rare disease space. Hereditary angioedema has 8 FDA-approved HAE medications, and there's actually a handful more on the way, which is pretty exciting. Unfortunately, having the FDA-approved medications, which a lot of the speakers have spoken about, looking for those treatments is only the first step. Once those medications get approved, Then there is the problem of actually being able to access and afford that medication, and the barriers that the insurance companies continually throw up in the way of actually getting them. So I wanted to show this slide to give an idea of what my medications cost. I'm on 2 medications right now. One is a prophylactic treatment. So the purpose of the treatment is to try to prevent the attacks of my disease. My disease presents swelling. I just spontaneously swell like you would swell if you closed a car door on your hand. But my swelling is in my face, my lips, my tongue. It can be in my airway. If I am not able to treat my attacks when they occur, they can be painful. They can also be fatal. So treatment is a key method to being able to manage the symptoms of the disease and be able to allow me to lead my life. My prophylactic treatment, which is one of the newer drugs that is approved, I take 2 doses a month. The total cost of the medication is $46,800 a month. My medical plan passes on $14,200 of that cost to me every month.
Oh.
So $170,000 a year. My acute treatment, my prescription for it, unfortunately, in my case of HAE is a little more severe. I have a lot of attacks. I need to treat them. I get 10 doses a month, which costs $138,000. My plan passes $2,800 of that cost on to me. One of the ways that access to these medications is made much more burdensome to rare disease patients is because of the high cost of these medications. My insurance company and many others have decided that these are not actually essential medications as defined by the Affordable Care Act. So they're gracious enough to offer them in their plan, but any patient cost or out-of-pocket cost does not count towards plan minimums. I have a $2,800 maximum out of cost per year for my prescription plan. If I were to actually pay any of these patient costs out of pocket, they don't count. I still have to pay them every month, $170,000 a year, because it's not actually essential medicine according to the insurance company. Now, I'm lucky. My company that I work for has a benefit. I see no out-of-pocket costs. If I did see them, I would not have access to the medication. And just briefly, so the other side of this, one is the cost and the passing on of the cost to patients. The other side of the burden of access to medications is how difficult the insurance and companies actually make to get treatment. So my insurance prescription plan, which is provided by CVS, has a policy in place. Every of these medications requires something called a prior authorization. Anyone who has any rare disease medication knows how painful that process is. It's an abyss. My prescription plan has a policy that they automatically deny the initial submission of any prior authorization for these medications. They don't care what it is, they just deny it, and they force an appeals process, which consists of denial after denial after denial. The most recent round I've taken with my 2 medications this fall was that I did not meet a very strict set of guidelines for what is considered diagnostic to be able to take these medications. The diagnostic guidelines, the insurance company using excludes 90% of people with my diagnosis. So they've essentially said, we're going to make these medicines available, but you can't have them. You don't meet this very narrow definition. Now, I was able to get the medications, but I had to email the CEO of my company, which is a very large national company that's listed on the Dow, to get help. Once he inquired about the status of my issue, it was miraculously approved. 2 months later, I had to do it again for the other medicine. The executive vice president for benefits for my corporation, once again, had to intervene to be able to get these medications. These are the burdens, the countless hours. My wife does it for me because I can't talk to the insurance companies. It stresses me out, which causes attacks of my disease. Spend days and hours on the phone just to get bounced from person to person to person with no actual answers. My physicians have to spend days and hours on the phone and going through appeals just to get access to the medicine that he has already prescribed because he is an expert in the field and knows what he's talking about. I have capabilities. I have a job. I have a company that cares for me. A lot of rare disease patients don't necessarily have the full support structure I do, but they have every right to get these treatments just as I do. They need someone to fight for them. The Rare Disease Advisory Council can help be that voice, fight for their access, fight for the healthcare regulations and the insurance regulations.
Dave, I want to thank you for your.
Thank you.
We have a hard finish right now. I'm sorry. Go ahead, Father Nick. You can close.
Thank you to all of our speakers, to Nord, to all of our sponsors, all those in industry, and most especially our patients and patient families for their honest and heartfelt testimonies today. And all of us are in agreement that the Rare Disease Advisory Council will go a long way in helping us to bring up more of these issues so that legislation and all of what we do in our daily lives can be made a little less stressful, so that we can be contributing citizens of this state, of this world, and to honor the life of so many people who are rare. Alone we are rare, together we are strong. I thank you all for gathering this day and look forward to a safe return in 2023, God willing, in the Legislative Office Building. And maybe sooner than that, we'll all have occasion to be at the Legislative Office Building for other testimonies and public hearings. Again, thank you to Nord and everyone who has attended. Have a blessed and peaceful remainder of the day and a beautiful weekend.
Thank you, everyone. And I will be sending you all emails asking for your testimony on our bill. Thanks. Have a great weekend. You did a great job. It was a wonderful presentation. Thank you all.
Thank you all again.
Thank you.
Thank you to everyone who spoke. Thank you to everyone who came and listened. Thank you again. I hope you have a great weekend.
Thank you, Hunter, and a shout out to our co-MCs, Hunter and Katie. It's a great honor to be on the virtual stage with you, and I can't wait to collaborate more in the future, guys. Take care.
Likewise, Father Nick, this was my honor. Thank you all.
Bye-bye.
Thank you.